Good evening, everyone, and welcome to the Canadian Concussion Center's webinar series, which is sponsored by LiUNA, the Laborers International Union of North America. I'm Leslie Rattan, and I'm pleased to be moderating our webinar series, which has been developed for individuals that have suffered a concussion, their caregivers, and healthcare providers. Our sessions, if you've attended before, you'll know, focus on various symptoms of concussion. And we have an expert speaker for our first half, followed by a question and answer session for the rest. And our sessions have been running every other Tuesday night from 6 to 7 p.m. We've got one left in the series. Know that you can submit questions at any point tonight. If you look at your app, you'll see a Q&A on the far right. So if you click on that, that is the place to enter your questions for Dr. Snaiderman. And if you're having any technical difficulties, please enter those into the chat as opposed to the Q&A. So all questions go into the Q&A. So tonight is our 15th session. If you missed any of the previous ones, you can find these on the Canadian Concussion Center website. All of those videos are posted there. And for this evening's session, I'm really pleased to have Dr. Snaiderman back with us again. And he's going to be presenting drugs for neuropsychiatric symptoms of concussion. Dr. Snaiderman is an assistant professor in both the Department of Psychiatry and the Department of Medicine at the University of Toronto. He is the founding director of the Neuropsychiatry Clinic at the University Health Network, Toronto Rehabilitation Institute, Brain and Spinal Cord Program, where he's worked for the past 25 years. He's been involved in the field of physical and neurologic trauma for many years. As a clinician teacher, he has been involved in training medical students, residents, fellows, and ancillary health professionals, as well as the general public over the past 25 years. He's a member of the exam board and an examiner in psychiatry for the Royal College of Physicians and Surgeons of Canada, and winner of the Ivan Silver Award for Excellence in Mental Health Education, given by the University of Toronto. He's a member of the board of directors and advisory board of several acquired brain injury organizations, initiatives, and programs. And I'm really pleased to introduce Dr. Snaiderman. I'll turn it over to you.
Thank you, Dr. Rattan. Once again, torture an audience. If you attended my previous presentation a month ago and you survived it, welcome back. I'm gonna now share my screen. All right, hopefully everybody can see it. So the title of the presentation is Medications for Neuropsychiatric Symptoms of Concussion. And as we always do, we start with my disclosure, which is that there's no conflict of interest. I am going to be talking about generic medications and medication used off-label, meaning not necessarily for what they were developed. I will try to avoid as much as possible commercial names. I have no affiliation with pharmaceutical industry whatsoever. I am a clinician teacher, not a recorder, hence not a researcher, hence no research was harmed in the making of this presentation. I have 30 minutes for the presentation, and like I said last time, we'll try to go as fast as possible. So if you attended last month my presentation, you know that my philosophy and the philosophy of the field of neuropsychiatry of late is that mind equals brain, brain equals mind. In this illustration, the creative side is the right one, the logical side is the left. In reality, we're best served if we think of the brain as a humongous network connecting everything to everything else. There are many, many neuropsychiatric problems after mild traumatic brain injury. I will not discuss severe traumatic brain injury or moderate traumatic brain injury. Some of these items are depression, anxiety, sleep disruption, memory issues, energy issues, substance use, and many, many others. Due to the problems with time, I will only be able to speak about depression, anxiety, and sleep disruption specifically. Now, we in medicine, in psychology, and all the health sciences consider symptoms as a continuum. What do I mean by that? Symptoms are the complaints the patient presents with. Signs are the subject matter that we can see as clinicians. So the complaints that we can see as clinicians. So symptoms are what the patient tells us, symptoms is what we observe, signs is what we observe. So for example, in this continuum, we have on my left, your left to imagine, worry, anxiety, muscle tension, palpitations. And then on the other side, depressed mood, anhedonia, appetite, disturbances, worthlessness, feelings of suicide. So on one side, we have more of an anxiety picture. On the other side, more of a depressed picture. But in the middle, both share sleep disturbance, agitation, difficulty concentrating, irritability, fatigue. Now, if we move on to a diagnosis continuum, we have a very similar picture. On one side, we have a major depressive disorder. On the other side, we have a generalized anxiety disorder. And in the middle, what's more often seen after a concussion would be comorbid depression and anxiety. Now, we jump to the treatment continuum. Not surprisingly, since both syndromes, depression and anxiety, share neurological background, share anatomical background, share psychosocial stressors, the treatments for anxiety and depression are similar in terms of the medications we use. Both disorders can be treated with so-called antidepressants. Now, since I already spoke last month about depression and anxiety and sleep disorders, I'm not going to spend time talking about them, but rather concentrate on the treatments. We have, I'm very happy to have a mix of patients, caregivers, and healthcare professionals. So we have to fit all of it in a presentation that's friendly to everyone. So I want you to watch this video and pay attention, particularly at the end, on the illustration, the video of the neurons and how do they look and the synapses. I hope you can hear it.
A child's experiences during the earliest years of life have a lasting impact on the architecture of the developing brain. Genes provide the basic blueprint, but experiences shape the process that determines whether a child's brain will provide a strong or weak foundation for all future learning, behavior, and health. During this important period of brain development, billions of brain cells called neurons send electrical signals to communicate with each other. These connections form circuits that become the basic foundation of brain architecture. Circuits and connections proliferate at a rapid pace and are reinforced through repeated use. Our experiences and environment dictate which circuits and connections get more use. Connections that are used more grow stronger and more permanent. Meanwhile, connections that are used less fade away through a normal process called pruning. Well-used circuits create lightning-fast pathways for neural signals to travel across regions of the brain. Simple circuits form first, providing a foundation for more complex circuits to build on later. Through this process, neurons form strong circuits and connections for emotions, motor skills, behavioral control, logic, language, and memory during the early critical period of development. With repeated use, these circuits become more efficient and connect to other areas of the brain more rapidly. While they originate in specific areas of the brain, the circuits are interconnected. You can't have one type of skill without the others to support it. Like building a house, everything is connected, and what comes first forms a foundation for all that comes later.
So I love this video because first of all, the graphics are fantastic and you get to see what the synaptic connections are like and how the brain is fully interconnected. Okay, so if we look further, this is the small illustration on the right side of the screen is how I learn neuroanatomy through pictures. And this is actually a 3D scanning microscopic image on a culture medium, which you see two neurons approaching each other and touching and caressing. And one of my residents called this slide 50 Shades of Gray Matter. But anyway, so you can see the synaptic on the red circle in the right hand of your screen and two more synapses in vivo. And that's how they actually look. But if we look closer, they are all functioning with a very simple lock and key mechanism. What do I mean by that? Imagine the pink upper circle is one neuron, and the space between them is what we call the synaptic cleft, this tiny microscopic space between this neuron, this one, and this other neuron. And this is, let's call it dopamine, a neurotransmitter, or serotonin, which is released when this vesicle inside the cell approaches the membrane, fuses with the membrane, releases the neurotransmitter, which then floats into the next neuronal, into the next neuron, locks in with its appropriate receptor, and triggers a signal. Now, if we have another type of neurotransmitter, like an opiate, say morphine, this will not fit in this receptor, but it fits in this one and creates a transmission towards that neuron. Once the serotonin or dopamine key enters the lock then releases second messenger, other substances here throughout the cell that then trigger the electrochemical stimulus to produce the neuronal firing and neuronal messaging. Now, once again, imagine that the vesicle inside the cell in the presynaptic neuron, releases dopamine. The dopamine floats into the receptor or the lock, does its thing. The receptor spits out the dopamine molecule, and what happens? Some of them float in the synaptic cleft. Others are picked up by a protein or a transporter that picks it up and almost like an excavator pulls the dopamine or the serotonin or whatever neurotransmitter back inside the presynaptic cell to be recycled. So we call this reuptake. So what would happen if this lock and key mechanism gets optimized by blocking the reuptake, this area? We stop recycling it, and hence this molecule drops again into the synapses to be used again. So essentially, instead of wasting the neurotransmitter, we enhance its capacity. And that's called a reuptake inhibitor. There are many, many neurotransmitter families and hundreds, if not thousands, of neurotransmitters. The most commonly ones that you might hear of is dopamine, implicated in Parkinson's disease, in schizophrenia, norepinephrine or epinephrine, which are also called noradrenaline and adrenaline. Epinephrine comes from nephron, kidney, epi, above, which is the suprarenal gland, which is all of these. Some of these hormones are produced there. We have serotonin, melatonin, many of you might have heard of it, which are neurotransmitters. Many, many others, including oxytocin, for example, in deliveries, in milk expression after pregnancy. Insulin is another neurotransmitter, thyroid substance is another neurotransmitter, etc. If you remember, and you were awake from in my last presentation, I showed this slide in which this is the area of the brain where all of this cellular nucleus, neurons live here that produce orexin, dopamine, acetylcholine, or adrenaline, serotonin, histamine, etc. And when they are produced here, they are then transferred to the rest of the brain by long, long axons in the cells that transfer the neurotransmitters to the rest of the brain. So when there's an injury in any of these areas, we have problems in neurotransmission and problems in mood. So if we're going to target these neurotransmitters to treat mood and anxiety, it makes sense to keep that in mind. So what are antidepressants in themselves? This is my definition: group of medications or interventions associated with a decrease in symptoms and signs of depression. It's one of those duh statements, right? Now, non-medication interventions include exercise, highly underrated but very effective, psychotherapy of various types, meditation, social contact, electroconvulsive therapy, transcranial magnetic stimulation, light therapy. All of those are interventions that are not necessarily medications that can help depression and anxiety. So medications, which is what we're talking about. Some people categorize them as old, 1950s, 60s, and 70s. And the younger I get, the more upset I am by this classification. New-ish, 1980s and on. And the type, which neurotransmitters are targeted. This is a bit of a busy slide, but we go through it very quickly. It's a very nice chronological history of what came first. So the first antidepressants were really rough, called the MAOI inhibitors, monoamine oxidase. Monoamine oxidase is an enzyme that destroys neurotransmitters. So if we inhibit the enzyme that destroys the neurotransmitter, we have more neurotransmitter. Unfortunately, they were very complicated to use because unless you adhere to a very strict diet that consisted of avoiding many foods and beverages that have tyramine, you can actually have a hypertensive crisis and die. So they were not very popular. After that came the tricyclic antidepressants, which many of you might be familiar with, especially amitriptyline or nortriptyline. Imipramine is the first antidepressant and the gold standard against any further antidepressants have been compared to. Why are they called tricyclics? 1, 2, 3 rings, benzene rings, so tricyclics. If we add a chloride atom to this imipramine molecule, we have clomipramine. If we have an NH molecule, we have nortriptyline. And then came the tetracyclics, 1, 2, 3, 4 compounds like amoxapine that weren't very popular, and bupropion, which came out a long time ago. Unfortunately, bupropion, the first time it came out, there was a contamination in a sample at the factory, and it came in immediate release, and people were having seizures, particularly for a batch in Japan in the late 1970s. So bupropion came out of circulation until the manufacturer realized what happened. They switched bupropion to a slow release form, and the seizure problem was decreased dramatically. This is the only one that does not have sexual side effects, but has other issues that we'll talk about later. So after the tetracyclic and unicyclic, you see only one ring, came the serotonin antagonist reuptake inhibitors, the SARIs. Of the most famous one would be trazodone, and I will be talking about it later. And then in the early 1980s to mid 80s, the SSRI selective only affects serotonin. And now you're experts in psychopharmacology and you know what reuptake means. It inhibits the reuptake of the molecule and specifically to serotonin. The first one was fluoxetine, Prozac. The second one, sertraline, Zoloft. Very, very well tolerated. When we were using tricyclics, we needed to use blood tests to assess the level of the medication and do electroencephalograms, my apologies, to see what was going on with the levels. It was complicated and they were very sedating. And the last one I'm going to talk about, or there are many more developed afterwards, is the SNRI, so serotonin, and we bring norepinephrine reuptake inhibitors. So these guys are able to inhibit the recycling of both serotonin and norepinephrine. So which one's the best? Yeah, I know it's kind of tacky, and the Oscar for the best antidepressant goes to, drum roll, imipramine. Despite all of the agents that have been developed ever since the 1950s, none has been as effective as imipramine. Imipramine is the gold standard by which newer antidepressants in research studies get compared to. So let's give imipramine. Oh, unfortunately, imipramine could not be here to receive the award due to the rather difficult to tolerate side effect profile. But in imipramine's absence, her daughters, the cipramine, clomipramine, and amitriptyline will be, oh, wait, they have the same side effect profiles. So again, we're not giving them the Oscar. So the types, tricyclics, MAOIs, SSRIs, SNRIs, and the atypical. So we're going to focus mostly on this group, given that the other ones are hard to tolerate. Now, I want to remind the audience that the best results article in research after article in research has proven, study after study, that the best results are achieved via combination of medications and talk therapy, psychotherapy. Medications alone are effective, but not as effective as psychotherapy. And in some forms of depression, psychotherapy alone might not be enough. So I'm going to show you what my job is, basically. My first job is, what is the diagnosis the person in front of me presents with? Is it post-concussive syndrome, but does it have depression or an anxiety disorder? Is the patient acutely delirious because of an infection? Does the patient is old and has dementia? Are there any other medical conditions that might be affecting the patient? So those diagnoses, are there other diagnoses? For example, sleep, pain, other medical issues, anemia, iron deficiency, B12 deficiency, thyroid, autoimmune disorder, infections. And then I have to tell the patient what is the right medication for the right diagnosis, at the right dose, in the right patient, at the right time, for the right duration. Piece of cake. There are important personal factors in determining which medication is best in the post-concussion patient population: age, gender, level of education, social and financial situation, litigation, past medical history, past history of mental illness, etc. There's also the patient personal preferences. Has the patient have experiences? What do they prefer? Past experience exposure to the antidepressants, and family history. If Mrs. Smith has depression and Mrs. Smith's mother had depression and responded to sertraline, chances are she will too. And also cost. Some of the newer antidepressants are very good, but very expensive. And there aren't many differences in terms of response. The issue of generic versus brand name comes at times. So which one? In mild traumatic brain injury, i.e. concussion, the scientific literature is very limited. It is extremely difficult to gather a large pool of patients that are willing to be part of the research. So evidence favors the use of the SSRIs, no question. Now, the general strategies are use the least invasive option, start low and slow. Side effects are more common and more troublesome in traumatic brain injury. So we have to go really slow with very small increases. I tend to explain a lot to the patients what are the side effects, the nature of them being temporary, how well tolerated these agents are, and how in communication will remain in case of trouble. Now, this is the bummer. There is a lag time between the patient taking the medication and the response to the medication. For reasons that are complicated, and I'm not going to get into, some patients respond very quickly within a few days. That's because the reuptake inhibitors can happen in other parts of the neuron that respond very quickly, but the actual effect needs to go inside the neuron and develop a whole bunch of protein cascade that needs to get sent to the synapse. So lag time, 4 to 6 weeks. Wait, what? 4 to 6 weeks I have to wait? No other choice. So the research available shows that two agents, sertraline or citalopram, are the better tolerated and the ones that respond the best. And this is, of late, there's been some controversy about this one, but overall in my clinical practice over many years, I've seen patients responding to this too. Doesn't mean that the other ones are not effective, are not good. It's just that the studies have only been done in these two. So the second line would be venlafaxine, otherwise known as Effexor. Although I sometimes use venlafaxine instead of sertraline, particularly if the patient has a lot of issues with pain. I tend not to use the other serotonin, noradrenaline, or norepinephrine reuptake inhibitor called duloxetine or Cymbalta, because I've had very poor results. It's way more expensive than venlafaxine. There's never been a study that I'm aware of that compares these two, venlafaxine and duloxetine, against each other, showing that Cymbalta is better. So why have more side effects with duloxetine that can affect cognition when we can use venlafaxine without those side effects? The third line would be the tricyclics like amitriptyline and nortriptyline. Now, some of the patients that have concussions have been put on amitriptyline because of headache prophylaxis, and that is fine because it does work. It helps prevent headaches. So in those patients, amitriptyline is not being used necessarily for antidepressant. For amitriptyline to be used as an antidepressant, it would have to go to the 120, 150 range at a minimum of 75 to 100 milligrams, which is quite sedating. And instead, our colleagues in neurology or rehabilitation medicine use 10, 25, 50 milligrams of amitriptyline or nortriptyline. Stimulants, a lot of research about methylphenidate, otherwise known as Ritalin, of late, and its capacity to help patients with depression and also fatigue and anxiety. It has some side effects that one needs to be careful with, and less than ideal bupropion. Bupropion has nothing wrong with it. That's the one we're talking about seizures. However, in somebody with a head injury or head injuries, I'd rather not lower the seizure threshold. In other words, not increase the risk of seizures in the patient unless we have absolutely no other recourse. And I definitely avoid the ones for which you have to be very strict in your diet, what you eat and what not, especially in a patient that might have cognitive issues. Rate of response, how many people respond? Not every patient will respond to the first antidepressant. About 75% or so patients respond to the first agent, but not everybody. So a common issue is underdosing. I often get referrals from other centers, and the dose has not been increased yet when the patient might be what we call a fast metabolizer. It might be breaking down the antidepressant in the liver too fast and too much. So sometimes increasing the dose helps. Occasionally, in severe cases, more than one antidepressant is needed, what we call augmentation strategy. So for example, a patient might be on sertraline, and then I add an antidepressant of a second family like venlafaxine to boost the antidepressant, and it works. Now, remember this, the response of your best friend's forever second cousin neighbor does not predict yours. And please beware of Dr. Google. Anecdotes do not science make. So if you go online, and I'm sure many would have, you are going to find thousands of chat sites saying that antidepressants are the devil, and thousands of chat sites or forums that are going to say that antidepressants save their lives and they're the best thing since sliced bread. The reality is neither. Each patient will have their own response to the antidepressant. Each patient needs to try it and see for themselves what is good. Fear is a killer in depression. It's a problem when a patient is afraid of the side effects or afraid of a medication that enters my brain, when they're not realizing that Tylenol controls pain and fever by entering your brain. And so does ibuprofen, et cetera, et cetera. Now, a family history of response or personal history of response might predict yours, as I said before, and a very small minority of patients will not respond at all to medications, what we call treatment-resistant depression, in which case we might use other form of stimulating the brain that is not through medication. Now, what are the side effects? The bigger the bubble or the planet, if you want to see it in an atmospheric kind of way, galactic way, the more common the side effects. Sexual problems. And I had a very cute patient telling me, you mean that I'm going to have too much sex and that's going to be a problem? And my answer was, I wish. No. Chances are the libido, the drive is going to go down, not in everyone, and it's dose dependent. The higher the dose, the more common the issue. The capacity to have an orgasm might be delayed, or there might be ejaculatory delays, or there might be erectile dysfunction, depending. Those are not unusual. About the literature says about 25%. I think it's higher than that. Weight changes, whether it's going up or down on weight, fatigue, depending on which of the antidepressants we're using. And that's easily solved if we switch the antidepressant from daytime to nighttime. Gastrointestinal, either constipation or initial diarrhea. Sleep, some patients find the sleep is disrupted, other patients find the sleeping too much. Occasionally, we see patients with dizziness at the beginning, but that usually gets better quickly. Very rare to have coagulation issues. Serotonin exists in platelets, which are tiny pieces of cells that help us coagulate. So when we block serotonin, we might make the blood thinner. It's a very small risk, but nonetheless present, especially if the patient is taking other medications like aspirin or Coumadin or heparin or other agents that thin the blood anyway. Be warned, green tea is an anticoagulant. Other forms of supplements can be anticoagulants. So one has to be careful what one puts into our body when taking antidepressants. Extremely rare, there's something called serotonin syndrome, in which the patient, if they mix an antidepressant with a medication for cold or flu and cough, or other medications for headaches, for example, they might go on to have too much serotonin stimulation. And that can be, if not treated quickly, dangerous. It is extremely rare. In 30 years, I've never seen a case, but it's described in the literature. Headache is not uncommon initially, but it tends to improve rapidly. And heart rhythm, particularly in older patients that have heart disease or are taking medications for heart rhythm and blood pressure, the heart rhythm can be affected. That's easily solved by monitoring carefully and switching agents. The other bubbles are bubbles that I couldn't get out of the graphic, so my apologies. There are many other side effects. I always tell my patients, please don't look at the side effects on Google, because you're gonna find that you're gonna grow horns and howl at the moon when it's a full one. So please talk to me, talk to a reliable source, look into reliable sources, give the medication a chance, and you'll see that most side effects are temporary. So symptom continuum. We talked about sleep disturbance. So very quickly, let's talk about sleep disturbance. It is sleep disruption in mild traumatic brain injury is a very complicated issue. Almost every patient presents with some form of sleep issue. It tends to be multifactorial. By that, I mean many causes for the sleep disruption. The most common form is insomnia, which means difficulty initiating or maintaining sleep. Rarely do we see hypersomnia, which is patients sleeping too much, or parasomnias, which means disrupted sleep in other ways. So for example, restless legs, nightmares, sleepwalking, sleep talking, etc. It is not unusual for patients that have a pre-existing sleep problem to then have a concussion and continue to present with a sleep problem. So a careful history of sleep needs to be taken into consideration. Very common for anxiety, mood, respiratory problems like sleep apnea, pain, neurological issues, environmental noise, hot weather, cold weather to affect sleep. So those of you who are Simpsons fanatics will recognize Nelson. Those of you who do not know who Nelson is in The Simpsons, you have wasted precious hours not watching it. So you have homework. So sleep medications are a complicated and careless bunch like this guy. So the benzodiazepines, or anything that ends in PAM, lorazepam, diazepam, clonazepam, there are many, many others, flurazepam, bromazepam, nitrazepam, alprazolam, etc. The PAMs are the benzodiazepines. The next family is what I call the Z medications. And they were marketed precisely with Zs to imply sleep. Zopiclone or Imovane, Zaleplon, and Zolpidem. These two might, I think Zolpidem is available in Canada and Zaleplon is not, or the other way around. The tricyclic antidepressants that we talk about, our friends amitriptyline, nortriptyline, doxepin, imipramine, and we use them for sleep because they are very sedating. So at smaller doses can be helpful. Antidepressants like trazodone, and a newer one, relatively new, it's already probably 10 years old or more, no more, called mirtazapine or Remeron. And others such as antipsychotics, quetiapine, olanzapine, aripiprazole, risperidone, and other categories like the over-the-counter medications, which essentially are antihistamines. They either have DM, dextromethorphan, or other antihistamines that are sedating. Others, and the interesting thing is that they are medications, but they are marketed as sleep aids to avoid regulatory issues. So which ones are the ones that are best used, and what are the warnings and problems? In very subtle colors, lorazepam, diazepam, clonazepam, the PANs and the Zs, I try to avoid like the plague if possible. I'm not always able to avoid them, but they are associated with very important cognitive problems, balance problems, motor coordination, attention, and concentration. So if the patient is taking any of these medications when they reach my office, I have to find out why, how long they're being prescribed. There's also a couple of, not a couple, quite a bit more studies lately over the past 10 years that shows association. And before you panic, association does not mean causality, doesn't mean that it causes, but association with dementia. So long-term use of some of these agents or all of these in red agents might be associated with dementia. We don't know if a patient with dementia has sleep disorders for which these medications need to be used, and they just happen to be an innocent bystander. There's not, these guys cause Alzheimer's, no, but there's some association. Some association with amitriptyline or triptyline doxepin and imipramine, although not as marked, but they also affect attention, concentration, memory, balance, motor coordinations because they're sedatives and they stay in the system quite a while. Quetiapine, olanzapine, and aripiprazole, antipsychotics, I can tell you that I have probably 2 or 3 patients in all of the years I've been doing this that I needed to use an antipsychotic like quetiapine or risperidone or olanzapine to put them to sleep because nothing worked and they were desperate. And by then it's usually my colleagues in sleep disorders, which I consult to, that would recommend that. Antihistamines, I never use them. Again, the reason why amitriptyline or triptyline doxepin and imipramine, the tricyclics, put people to sleep is because they have antihistamine actions, and antihistamines are sedating. So, come on, guys, I have to do it. And the Oscar for the best sleep medication goes to, drum roll, absolutely none. Why is that? Because sleep disruption in mild brain injury is usually secondary to an underlying cause. It is extremely rare to see a primary neurologically based sleep disorder due to brain injury. Not impossible, but unlikely. For example, if the patient has sleep apnea, they snore like a locomotive, keep the partner awake all night, stop breathing in the middle of the night 30, 40 times an hour, a CPAP mask might help the sleep problem without medication. If somebody has severe muscular or bone pain, using a pain medication like long-lasting Tylenol might be able to solve the sleep problem, etc. Depression, treating anxiety. Cognitive behavioral therapy for insomnia, the so-called CBTI, highly effective. It is a bit of hard work for the patient because they have to implement the exercises, but all the research is showing that perhaps is the #1 treated for insomnia. And there are manuals available for the patient to use. Exercise. I cannot recommend exercise strongly enough as a treatment for sleep disruption. It is very hard to start, very easy to drop out, and it takes about 3 months for somebody to get used to the exercise. But once they do, and they're exercising 5 times a week for 30 minutes, almost invariably quality of sleep improves. Structure bedtimes, what we call sleep hygiene measures. Go to bed at the same time, try to get up at the same time, and try to avoid naps. Avoid caffeine, alcohol, cannabis and recreational drugs, tobacco, Screens, any kind, any size, 1 hour before bedtime. Did I mention exercise? Limit liquids 3 hours before bed so you don't have to wake up in the middle of the night. That's another example. I've treated patients with severe depression by sending them to the urologist and have the prostate taken out because they couldn't sleep more than an hour without waking up to pee. So I have that experience of sending patients. And did I mention exercise? Hold on, let's sleep on it. Okay, if there is a need to use medications, the least complex and benign medications in the context of mild TBI are trazodone and mirtazapine. And trazodone can be started at a quarter of a tablet for 1 night. And if it doesn't work, the next night can be started at half a tablet. And if it doesn't work, the next night at the tablet, or a tablet and a quarter, a tablet and a half. Non-addictive, not habit forming, which I forgot to say that the benzodiazepines are. You can take it if you need it or not take it, and there's no withdrawal. So very benign medication. It does have side effects that need to be dealt with, has to be taken an hour at least before bedtime because it doesn't work right away. So if you take the medication at 10 and you want to fall asleep at 10:30, not gonna work. You have to take it, think ahead of time and take it ahead of time, both of them. And I'm gonna finish with this. This is an article that I read this week that was published this week about SARS. And the article says, the title says, mortality risk among patients with COVID-19 prescribed selective serotonin reuptake inhibitor antidepressants. And like my grandmother said, I read it and I went, oh, vey. Now they're gonna tell me that the SSRIs are involved in mortality, and they are, except the other way around. These articles concluded that the use of SSRIs may reduce mortality among patients with COVID-19, severe COVID-19, although they may subject to unaccounted confounding variables. So they are using people who are very, very sick in the ICU. They're using an antidepressant called fluvoxamine. And all of a sudden, they're realizing that patients are doing better. Why is that? Because it opens the whole chapter of whether depression and anxiety are inflammatory illnesses of the brain. And we know that selective serotonin reuptake inhibitors, the SSRIs, have anti-inflammatory, and SNRIs too have some anti-inflammatory effects. So this is fascinating. It's a new window that opens up into the reasons why people get depressed. So most of the treatments I implement in my practice have to be subjected to a trial and error. And that's how science goes. And like this cartoon says, poof, God as a kid tries to make a chicken in his room. So trial and error. And with that, I'm going to finish the presentation. About 10 minutes late, my apologies. I'm going to stop sharing. All right.
Great. Thank you so much.
Thank you.
Excellent presentation. I'm going to jump right into the questions because we have a number of them. The first one is, what are the negative effects of Cymbalta, and is it easy to wean off? Is this a good medication for depression?
Fantastic question. Cymbalta is an SNRI. Both, I'm going to use duloxetine because I don't like to use commercial names. Duloxetine is Cymbalta. Duloxetine is an SNRI, and it was marketed about 10, 15 years ago as a pain diminishing antidepressant. And the commercials in the States said, depression hurts. You might have seen them here in Canada too back then. In reality, both medications, venlafaxine, Effexor, and duloxetine, Cymbalta, have to be weaned off very slowly. I had a patient that was on duloxetine, 60 milligrams, went traveling, forgot the medication, and I got a panic call from El Salvador or Costa Rica, wherever it was, because the patient was having a really tough time. You cannot stop them abruptly. They have to be weaned off slowly. Cymbalta is a more anticholinergic agent. By that, I mean that it is a medication that blocks a neurotransmitter called acetylcholine that happens to be one of the main neurotransmitters involved in memory. The same thing happens with tricyclics like imipramine, and The same thing happens with other medications that are anticholinergic, so medications for urinary incontinence, for example. So that is a major issue. Otherwise, it has the same side effects as other medications. I tend not to use it, except if I tried everything else and nothing works, or the patient comes to my clinic already on duloxetine and is having a good response.
Great, thank you. Doris asks, what do you think of using medical marijuana for TBI clients?
I'm going to be really quick about this one. There are very good quality studies that show that cannabinoids, not just marijuana, hashish, etc., affect mood negatively, affect attention, concentration, motivation, speed of process. Furthermore, a recent article this year was very troubling because it demonstrated in their study, it wasn't a great study, but demonstrated that long-term use of cannabinoids might be associated with psychosis, with having delusions and hallucinations. So if the patient has a degenerative, progressive neurological illness that's not going to get better, it's in excruciating pain, horrible spasms, or has multiple sclerosis, end stage, and we're not worried about their cognitive skills or their mood, fine. In any other circumstances, I don't recommend it. I know this is contrary to current policy and socioeconomical status of marijuana. Nobody asked the medical community whether we agreed with legalization. We were kind of flabbergasted that they completely ignored the research, but it's here, and what are we going to do? The short answer is no, we don't recommend it. Very hard to stabilize somebody's mood if they're using cannabis. There are there are 130 plus known compounds in cannabis, and we only know 2, THC and CBD. We don't know what the others do.
Okay, great, thank you. Are the symptoms of depression secondary to concussion different from primary depression?
Excellent, very good question. They can be identical, but there are some differences. Patients with concussions, and this is a topic I dealt with in last month, tend to have more physical symptoms, so more pain or headaches or fatigue. They tend to be more irritable, more impatient. But the other symptoms are identical.
Okay. Margaret asks, I've been taking gabapentin for 1 year as per my neurologist and will be seeing my psychologist tomorrow for an assessment. Can I take gabapentin if I am prescribed an antidepressant?
Yes, carefully, because both can interact, especially if the antidepressant is sedating, because gabapentin can be sedating. But I have many, many patients on gabapentin and antidepressants. You have to be careful. It has to be done by somebody who knows what they're doing.
Okay. Do patients with depression secondary to concussion require lifelong treatment with an antidepressant? And how long do patients need to be on antidepressants after the 4 to 6 weeks?
The natural history of depression, in other words, if somebody gets depressed, survives the depression, they don't kill themselves, they don't have heart attacks, or they don't have other comorbidities, other problems, the natural history of a depressive episode is about 18 to 24 months. So left on its own, that's how long an episode of depression lasts. Now, if this is the first episode of depression, that's how long I would keep the patient on the antidepressant, minimum of 1.5 years to 2 years. And then very gradually, over a period of months, discontinue the medication and then monitor. If the patient relapses into depression, we start again. If the patient relapses again after discontinuing the medication, that means they need to be on it probably long-term.
Okay, great. Joel asks, along with nortriptyline being prescribed first line for prolonged post-TBI headaches, what medication best fits to address concurrent depression and anxiety?
Okay, so if somebody is on nortriptyline for headaches, any medication you can tolerate or your doctor prescribed will be okay with nortriptyline. However, it has to be started really slow, and if the nortriptyline dose is too high, needs to be lowered to prevent serotonin syndrome, to prevent negative interactions. There's no one particular medication that I would recommend to be added to nortriptyline. An alternative will be to increase the dose of nortriptyline. However, that we start getting into the side effect profile of sedation, constipation, dry mouth, blurred vision. If the patient stands up quickly, they get lightheaded, which is a side effect that often patients confuse with post-concussive dizziness. So I hope that answers the question.
Okay. Are sexual side effects for SSRIs or for all the other classes of antidepressants?
Oh, yeah. What can I tell you? Some of my patients tell me that I'm a killjoy because I made them eat a lot, gain weight, and not have sex. So I'm a party pooper. It's all of the SSRIs. Escitalopram, Cipralex has a little bit less chances of having sexual dysfunction, but it's mostly dose dependent. So the higher you go on the dose, the more the likelihood you're going to have sexual dysfunction in both genders, both sexes. The only antidepressant that does not affect sexual drive is bupropion. And as you saw, it's not first line. Bupropion can be okay for depression, not so good for anxiety. It can make some patients irritable and has the risk of seizure. So it's not my first choice. But unfortunately, it's one of those side effects that we haven't been able to figure out. There have been trials of newer antidepressants, but they do have the same.
Okay. Which antidepressant has the most side effect of weight change? And would this be weight gain or weight loss?
This is absolutely individualized. I'm even reluctant to answer the question because each patient is different. I can have a patient on mirtazapine, Remeron, put on 30 pounds, and I have a patient on mirtazapine not putting a pound. I can have a patient on sertraline lose weight and another patient on the same dose gain weight. Completely idiosyncratic individual response. We know that tricyclics, the older medications, tend to produce more weight gain. Mirtazapine, Remeron tends to produce more weight gain, but otherwise the other ones are completely idiosyncratic responses. Now, you don't put in the weight out of the blue by breathing in calories. What happens is that some of these medications or all of these medications tickle your sweet tooth. So it makes the patient crave carbohydrates. So the fourth meal, so they eat breakfast, they eat lunch, dinner, and then before going to bed, they start getting the munchies and they go for carbs. And usually the good stuff, chocolates and candy and cookies, and why not, right? So that's where the gain happens gradually, insidiously. It's not like cortisone or other steroids in which the patient puts on a huge amount of weight based on fluid retention and other side effects. This is intake related.
Okay. So we have someone talking about concussion anxiety not controlled by antidepressants, and they're asking, what would you use? They said that they went to their doctor and who refused to give the quick acting benzodiazepines.
Good.
That she thought would be the only thing that would help, but the doctor said they were too addictive and didn't want to.
Absolutely right. Keep your doctor.
Yeah, and she's saying brain would flip into crazy anxiety and out of control, and there was zero help from it aside from going into a dark room. So what might you suggest?
Now, I cannot do consultations during a presentation. I can only make suggestions because I don't know, Anonymous, your background, medical history. I'm not your physician, so I cannot recommend specific interventions. So in general, patients with anxiety will respond to the right medication at the right dose. So you might have to try other antidepressants. If the antidepressants are a good dose, you have to push the dose up, and you're still not responding, then a consultation with psychiatry might be necessary. Do not use benzodiazepines, especially the fast-acting ones like Xanax or Ativan, because they are very addictive, particularly Xanax. And the last thing you need is to get dependent on a benzodiazepine that you will have a really hard time coming off to. If you use alcohol or cannabis, the same thing's going to happen. You're going to rebound. So there are medications, exercise, non-pharmaceutical interventions, exercise, mindfulness, cognitive behavioral therapy, find out whether there are other issues happening in your body that might be producing anxiety. Are there other medications producing anxiety, etc.? But keep your doctors. If he or she refuses giving you a fast-acting benzo, keep the doctor.
Great. Would you prescribe melatonin as a sleep aid for those with insomnia?
Melatonin, amongst my colleagues in the sleep disorders field, is like religion. Either you believe in it or you don't. Some of them are recommending melatonin, particularly when it comes to jet lag. So traveling across time zones, melatonin is quite effective. Some patients find it very useful, and it works. It's benign. It's minimum side effects. You can start at 3 milligrams and increase to 6 or 9, 10. The problem with nutraceuticals, so-called natural substances, they're still chemicals. That's what sometimes drives me nuts. Patients that say they don't want to put any chemical in their brain and they don't want to take antidepressants, but they're using cannabis and alcohol and X, Y, or Z natural remedy. They're all chemicals. And it's just a matter of where they're made, the quality control, and whether they are research safe and effective. If melatonin is effective, great. It comes in 5 milligrams and in 10 milligrams, in 3 milligrams and in 6 and in 9, and long acting, short acting, and each manufacturer has a different formulation, but I have nothing against it.
Okay. I'm just conscious of the time, so I'll try and get a few more in here. So a couple relating to insomnia. One was asking, can you give a couple of examples of exercise done in CBT for insomnia? And then in terms of physical exercise that you were talking about, what kind would you recommend?
Let me start with the exercise, because as you can gather from my presentation, I'm a big proponent of it. It doesn't matter what you do as long as you're moving and you're schwitzing, you're sweating, and you feel your pulse going up and you're red. It can be yoga, can be climbing the stairs, can be walking. There's tons of videos online that are low impact, walk at home, really good videos for beginners. Go out for a walk, doesn't matter. What's more important is the frequency rather than the type. So 5 times a week, 30 minutes, start with 5, increase to 10, get to 30 minutes 5 times a week, and then see how you feel. So could be aerobic, could be dynamic, could be weights. Best thing, mix them. Do one day aerobic, the next day do resistance. You can buy your bands, TheraBands. Careful because they snap and they really hurt. Weights, calisthenics, whatever you want to do, but move. We need those muscles moving, producing endorphins. So any exercise that is going to allow you to continue doing it, and take vitamin M motivation, because it's hard to start. Trust me on that one, it's hard to start. And the next one is the CBTI. I'm not a sleep disorder specialist, so I don't want to get into it, but I'm going to give you a quick example. So do you watch screens to fall asleep? Do you have your phone or your iPad or your laptop on? Avoid it. Do you have a TV? Avoid it. Go to bed at the same time every night. The room has to be coldish, hopefully a comfortable environment. Stop looking at the clock to see that it is 1:03, 1:07, and I'm still not asleep. Oh my God, what am I going to do tomorrow? I have this presentation at 6 and I'm not going to be able to be alert. What am I going to do? Etc. So that kicks anxiety, and that's going to wake you up. Relaxation strategies, mindfulness-based strategies. Stop worrying so much about not being awake, not being restored. Worry less about that. Worry less about the hours you sleep. For crying out loud, throw your Fitbit out the window or your iWatch out the window. Not out the window, but don't use it at night. They're not accurate. If they tell you that you slept 7 hours, of which 2 hours were effective, that just means that it's detecting movements, not necessarily effective. Okay, that's as far as I go.
Okay. All right. There's some great questions. I'm going to do a couple more and then we'll go a little bit over time here. We've got some good ones. Zoe asks, why would norepinephrine be targeted compared to serotonin alone?
Okay. You asked for it, Zoe. So here it goes. Imagine, I don't know, first of all, I don't know if I'm going to pronounce the darn word correctly, but you know those mobiles that you hang from the ceiling and it has several pieces like trapezes that you touch one and the whole thing move? Think of your brain like a chemical soup in a mobile. So you touch one neurotransmitter and everything else moves. So norepinephrine or adrenaline has been implicated for many, many, many years, decades, as one of the main neurotransmitters in the amygdala, in the limbic system, in areas that produce anxiety. So in animal studies, animals that are, without getting too technicals, that are stimulated in certain areas of the anxiety circuitry demonstrate high levels of norepinephrine activity. Using norepinephrine, perfect example, somebody who has an allergic reaction and has to use one of those injectors. Those injectors have adrenaline, and adrenaline is a fantastic medication for severe allergies because instead of the vessels completely, the arteries completely opening, it closes them. So it allows blood pressure to come up. It prevents edema by not allowing fluid to come out of the arteries. It also helps with the respiration. But many patients that use those injectors will tell you that after using it, they feel their heart going a mile a minute and they feel very anxious, almost panicky. That's because adrenaline produces anxiety. And noradrenaline is the ugly sister of adrenaline. It's one molecule removed from adrenaline. So there are anxiety producing medications. So why stimulate noradrenaline? Because in certain areas of the brain, the receptors for noradrenaline, norepinephrine, are not necessarily working well. So it's complicated. Too much noradrenaline might be implicated in certain spectrum of depression and anxiety. Too much might be implicated in a certain part of the spectrum of anxiety and depression. So hyperactive, not great. Hypoactive, not great. So in some cases, patients, when are prescribed antidepressants, they feel very anxious. And that gives you a clue in response that this might not be the right medications because they are already sensitive to this particular neurotransmitter being stimulated. It is not that by using these medications, you increase the level of serotonin. Don't go buy supplements that tell you that you're gonna have more dopamine and serotonin and norepinephrine. Don't save your money. It has nothing to do with it. You have enough serotonin in your brain. You have enough serotonin in your body, enough noradrenaline and adrenaline and histamine in your body. The problem is not the amount. The problem is what I showed you in the slide, that it's not being transported, that it's not reacting appropriately. That was a long answer.
Okay, two more, if we can keep you. Are antidepressants used when patients are having problems with mood regulation, but are not necessarily clinically depressed?
I will ask anonymous attendee at 6:48 to tell me the difference between mood regulation and clinically depressed. And I'm being facetious. Mood regulation is part of depression. So Mood regulation might be irritability, might be depression, might be mania, the opposite. In my last session, I touched on it a bit. Mood dysregulation is just another way of saying you're not able to modulate your mood. Might be depression, might be anxiety. So it's not so much the flavor, it's the capacity to tame down the circuitry, which is part of depression and anxiety. And yes, there are use, absolutely, first line of use for that.
Okay. And the final question, where in Toronto or probably anywhere else would you recommend going for extra help with medications beyond your family doctor?
Your friendly neighborhood psychiatrist. There's a huge shortage of any mental health professional, psychologist, psychiatrist, even more neuropsychologists like Dr. Rutan, which we're very lucky to have at UHN, and neuropsychiatrist. The waiting lists are horrendous. So start with a referral to a psychiatrist. And there are waiting lists, but if the medication prescribed by a family doctor is not enough or is not working, a referral to psychiatry is necessary for the medication. You also will benefit from being referred to a program that might teach you mindfulness. And again, I go back to exercise, whether it's yoga, meditation, there are other ways. But if you are bad enough to need medications and it's not working, you need a consultation with psychiatry.
Okay, thank you so much. I think
My
I better
pleasure.
call it an evening. Thanks for staying a few minutes late.
Oh, my
Great
pleasure.
presentation and some really great questions. Just for your information, you'll know that we'll be sending you a survey if you've attended any of these before. So if you have a couple of minutes and you're able to provide a bit of feedback, we would love that. We've got one more talk coming up in a couple of weeks. And actually, I will be presenting, and I'm going to be talking, a good segue there, about cognitive behavioral therapy and mindfulness and just some different non-medication mental health strategies. And just as a reminder to everyone as well, that you'll be able to find Dr. Snaiderman's recording from this evening, probably in a week or so, on the Canadian Concussion Center website. So you can find all of the talks there.
So if you haven't had enough of me, you can do the reruns in
Exactly.
Anyway.
Yeah. Thank you so much and have a good night, everybody.
Please fill the surveys because we presenters live and die from the feedback we get from you guys, and we can improve or stop doing what we do. Thank you.
Yeah. Thanks so much. Night.